you very much. Thank you very much, Casey. Let me try and share my screen here and see if it'll work. Should work. Okay, there we go. So the topic of presentation, as you know, is pain management relative to orthopedic procedures. How effective are they? And we'll cover the common orthopedic procedures and also some new information. For some reason, it's not advancing. There we go. So in terms of conflicts, I don't think I have any that really are of concern here. However, some of the research I'm going to show you is supported by the Hartley Foundation and the Hemophilia Foundation of Southern California. As you can see, I hold official positions with OIC and the Hemophilia Center, etc. So we'll talk about total hip replacement, several knee procedures, elbow procedures, including radial head excision and elbow replacement, ankle fusion and ankle replacement, and we'll deal with pain relief, but also durability. These reconstructive procedures are not going to be very useful to you if they don't last a long time. So that becomes an important consideration. So the two most, I just like you to try and think for a second, what do you think are the two most successful surgical procedures in terms of pain relief, function, quality of life, cost effectiveness of all surgical procedures, not just orthopedic, not just hemophilia related, all surgical procedures. So we'll see how you did. Top of the list is cataract surgery, which probably won't really surprise too many of you. It is a life-changing procedure, can be done quickly as an outpatient, is available to a lot of the third world countries, etc. Well, what do you think the second one is? This may surprise you just a little bit. Total hip replacement is the second in that list of procedures that are the most effective. So here is the first hip replacement done on a patient with hemophilia in 1972. It's not like today's hip replacement. It's kind of a resurfacing. The femoral head here, the ball part's replaced with just a shell. It's called a cup arthroplasty. That procedure was done by my father, 1968. So that gave rise to full-scale total hip replacements, and we see the standard Charnley type hip replacement. Dr. Charnley in England was knighted because of his work in developing the first hip replacements. However, there were problems in patients with hemophilia. You can see that it has a stem that goes down the shaft of the femur, a ball, and then a socket. Both of these are cemented to the bone. Cement on the socket, cement on the femur. If you look to the far right, you'll notice that there is sort of a dark area between the implant and the bone and the cement. That means that the bone has resorbed. That means that the implant is worked loose and the implant is failing and painful. So let's look at the early results of hip replacement in patients with hemophilia. And you can see 3 articles were written, one by myself and Dr. Casper. And the failure rate was not really acceptable. It was pretty high, bouncing around 30%. Various follow-up, ours were the longest follow-up, some of them relatively short. But the failure rate here with Dr. Kelly was, 41%. Dr. Kelly's a very capable surgeon. Let's see if I can get rid of that. So what do we think might have caused that? There was a lot of study on this. There was also a failure rate of conventional hips in non-hemophilia patients, which was a little high, but not as bad as in hemophilia. All right, so they decided through some research that the reason for the failure was that the plastic material in the hip was wearing, and that plastic material wore with tiny particles, and we'll talk more about that in a minute. And those little particles got in between the implant and the bone, caused a reaction. And you see that reaction here. Now, this is an uncemented implant. This is the next generation trying to solve the problem, okay? Uncemented, no cement. But here we are on the right after just a few years, the bone is greatly expanded. There's all kinds of dark zones where the bone has been eaten away. And this huge, huge area of bone loss up on in the pelvis on the acetabular side, the socket side. Here's another example of an article from 95 to 2003 with 17 patients, all hemophilia patients. And if you look at the progression in this article, you can see that the proximal femur, the upper part of the thigh bone, is just gone. And so is a large part of the pelvis. That dark area is bone that has been completely eaten away, no cement. So the problem never was the cement. Going backwards. So this is the problem. This was what was found. See if I can make it work in a conventional way. That's the socket of a patient who had a cemented total hip replacement. Here you see one of the early cemented total hip replacements. It's loose. You can see the dark zones around the stem. It doesn't look the way it should. And you look at the socket and the head doesn't fit anymore. That is all polyethylene wear. That's all wear of the conventional plastic. And that's what was causing the problem, not the cement. So polyethylene wear was the problem. It resulted in osteolysis, destruction of the surrounding bone. That led to failure fixation, which you've seen. The loosening of the prosthesis, which then became painful and had to have a revision. So what happened was Dr. McKillop, who was the head of the biomechanics lab at Orthopedic Hospital, developed a machine to test the implants to determine wear rates at much faster than they would occur in the normal person. So we could study different types of materials over a much shorter period of time. 1 month could equal 1 year. But he's the one that started that and won a bunch of awards for it. So what he found, he and the other investigators found, was on average, the conventional plastic wore at 1/10 of a millimeter a year. Doesn't sound like a whole lot, okay? That's the equivalent. This takes a minute to get your mind around. That is the equivalent of 500 billion particles. These are really, really tiny particles, but because they're tiny, they get in between the implant and the bone, and the body sends in certain cells to try and dissolve them, and it can't, so it dissolves the adjacent bone. The average person takes 1 million steps a year. So that resulted in 500,000 particles per step of the conventional polyethylene. That in turn caused a reaction to the bone. That caused a membrane to form. And in patients with hemophilia, that membrane bled, and that's why they had more trouble than the other folks, but even the regular ones had trouble. So this is a graph. It's very simple. Here is the conventional plastic material. As you can see, it has linear wear. The longer it's in, the more it wears. Here is the improved plastic material called cross-linked polyethylene. And cross-linking really is a matter of joining the molecules together. That makes it incredibly strong. And you don't see any wear at all. It's a flat line. So we studied the cross-linked polyethylene in hemophilia patients. And we had 17 patients with 19 hips. Keeping in mind, this is not knees at this point. You can see the distribution of A and B hemophilia. None of them had an inhibitor. At that point, we were still very reluctant to operate on inhibitor patients, at least not big surgeries. About a third were HIV positive with various CD4 counts, and all of them were HCV positive, which is no surprise. The study went on for 18 years. Median age of 57, and the hemophilia patients are younger when they need joint reconstruction. Median follow-up of 11.5 years, which is pretty respectable in terms of length of follow-up. So the results of the study were that there were no postoperative complications, no blood clots, and that's important, but hemophilia patients are less likely to have that problem. No infections, which we were thankful for, no revisions, and no additional operations for any reason. So a dramatic difference compared to the earlier results that I showed you. There was no detected acetabular wear on the pelvic side, no detected osteolysis of the bone, no detected femoral osteolysis either. So in conclusion, the cross-linked ultra-high molecular weight polyethylene, this new material, which is now the standard around the world, in addition to preventing infection, which is an important separate issue that we'll address, plays a major role in improving longevity of hip replacement and probably knee replacement also. So what about knee procedures? Well, we'll talk about a couple of things, mainly arthroscopic debridement, because for a number of years, patients with hemophilia would come in, the joint didn't look too bad. It wasn't completely worn down to bone. They had quite a bit of pain from the arthritic symptoms, and they had torn cartilages in their knee and one thing and another, and they were treated with an arthroscopic debridement. Go in with an arthroscope, clean up the joint in hopes that that would help. And that has been done both for hemophilia and non-hemophilia patients with essentially the same results. So here's a group of really good, fairly recent studies. And you can see that in these fairly large series of patients, the result was that the arthroscopic debridement was no better than a placebo, no better than PT and medical management like anti-inflammatories, and no better than PT alone. So we just don't do arthroscopic debridement much anymore. There may be an occasional instance. Now, it's not the same as a synovectomy. Synovectomy is reasonable, but not debriding a arthritic joint surface in hemophilia. So now we'll move on to knee replacement. Knee replacement is now the most common musculoskeletal procedure, surgical procedure in the US. Over 1 million of them were done in 2016. That's also a very common procedure in hemophilia. So if we look at pain relief from knee replacements, we see they're really, really pretty good. Now, these are different scales, okay? Some of them are visual analog scales, some of them are knee society scales. So visual analog, I think you're familiar with. The highest is a 10, is a 0. So the patients went from a pretty high visual analog scale rating of 7, 7.5 down to less than 1. That's very good. In our series, the knee society score maximum 50 is the lowest pain. So they also did very well. Westberg study, 93% of the patients had no pain at all. And again, knee society with Dr. Chang improved to a rate of 48, which was very similar to ours, and almost no pain after recovery. Keep that in mind. Recovery is a bit of a challenge for a knee replacement. So what can we do to decrease the pain after the surgery? A topic of this is pain relief, and I'm glad to say there has been significant progress made. This was a study where they would inject the knee with a variety of medications. This is a long-acting local anesthetic. This is an anti-inflammatory by injection. This is epinephrine to make it last long. And they compared the group that got that treatment to the control group that didn't get that treatment. And the amount of morphine the patients took in the first 48 hours was dramatically different. The control group was 87 milligrams. The treatment group was 18. The treatment group had lower pain at rest, lower pain with motion, and were able to go home 2 days earlier. We have modified that, and we have added a couple of additional medications. Morphine sulfate can be added, and that has a direct effect on the tissues, not like you do systemically. We add an antibiotic just for safety. We add tranexamic acid, which a lot of you are familiar with, and that decreases bleeding. And then we add a steroid, because that is a potent anti-inflammatory. So this is wonderful. This makes a significant difference, but this is an injection of materials that last typically 12 to 18 hours. Is not going to last you through your rehab program. Looking at knee replacement results, Dr. Silva and I published a large study of knee replacements, one of the largest, and we found that at the end of the follow-up, the range of motion on average was 72 degrees. Now that's not as good as most knee replacements in non-hemophilia patients, keeping in mind that some of these patients went into surgery with no motion to start. And maybe even though they had 72, we're very happy, but we're not happy. We would like them to have 120 degrees of motion. The reason for that is very, very clear. Patients with hemophilia develop scar tissue in their joints called arthrofibrosis. That arthrofibrosis can be severe, and it can result almost no motion at all. And at surgery, we can remove the arthrofibrosis, but the cells are still there, and it comes back with a vengeance. So this is something we're working on. It's research I mentioned. It's supported in part by the Hemophilia Foundation of Southern California, for which we're very grateful. This is an electronic gyroscope. It's a neat little gadget. As you can see, it's not very big. And it can do all kinds of things. It can measure temperature. It can measure acceleration. But what we're after is the gyroscope, because the gyroscope can report within less than 1 degree of accuracy, within 1 degree of accuracy, range of motion of your joint. And it's especially useful for elbows and knees. And it's just strapped on with a little Velcro strap. It can be attached to a computer either through Bluetooth or a direct wire. And then the computer puts up this image. Now, I apologize, it's not very clear because it's a photograph of the image, but it will tell you your exact range of motion as you move. Why is that important? Well, if you know exactly how you're doing, you know when to push a little harder, when to try a little harder. Maybe you could, and this all can be done at home. Maybe you put on ice packs, you do various things to try and improve your range of motion, and then, you know, Voltaren gel, whatever, but something to reduce the discomfort so that you can gain in range of motion. Otherwise, the only time you really know an accurate range is when it's measured by the physical therapist or by the orthopedist. So we are hoping that this will make a significant difference. Keep in mind, it's investigational. We have no financial interest in the device. It's commercially available. It's not used for this purpose. It's used for other purposes presently, but we are starting to use it on patients with hemophilia. So how about durability? We said that a procedure that relieves pain is great, but it's not of much use if it doesn't last a long time. So let's look at durability of knee replacement. And at the far right, you see survival at 10 years. And there are two numbers. The left number is the overall survival. The right number is survival on a mechanical basis. And the reason, by the way, I have to warn you, we have a house cat. And he likes to be the center of attention. So I just heard him. He's sitting over there. Anyway, you may see him. Overall survival from a mechanical basis is quite good at 10 years. This one's a little bit lower, down Ernst Bruner's study, but that also was the longest follow-up. But what about this other number? What about the fact that survivorship for any cause is much lower? That is infection. And if a knee replacement gets infected, it's a big deal. It often means we have to take it out, resolve the infection, put another one back in. So in the early 90s, early to mid 90s, late 90s in one case, there were a bunch of articles on the survival of knee replacement in patients who were HIV positive, and they found that they had a much, much higher rate of infection, and everybody thought, well, the reason for that is immune suppression because of HIV. It's not an unreasonable thought. Sorry. I I'm gonna have to turn my light on. I can't see what I'm doing. There we go. Okay. Now let's look at knee replacement compared to hemophilia in non-hemophilia patients. So you look at very large database studies. These are often Medicare database studies, 100,000 patients or many more. And the average knee replacement survival or average for any cause, infection or otherwise, was an infection rate of only 1.5%. Total hip was even better. So very unlikely to get infected compared to the hemophilia patients. So if we look at total joints, a number of articles that were written, including ours, on total joint replacements of all types, 556, average follow-up 7.6 years, average rate of infection was 8.6%. That's basically 8 times the non-hemophilia population. But there was no difference whether the patients were HIV positive or negative. Keep in mind that Dr. Ragney's study was based on patients who had AIDS, who had CD4 counts under 200. They were sick people, and it's not surprising they would have had more trouble with infection. So the question is, if it's not HIV, what is the cause of prosthetic joint infection in patients with hemophilia? And we thought it might be IV self-infusion. This had been postulated by Dr. Ragney and others as a possible cause. So we began a study in patient education on sterile technique. And Chris Kashida instructed all of our patients in meticulous sterile technique. We told them how important we thought it was of the apparent relationship between IV self-infusion and joint infection. And they were reminded at every visit. They probably got tired of hearing it. And then we studied that group. So we looked at primary infection and secondary infection. Primary infection is a total joint infection of hematogenous blood-borne origin without a known source. Secondary infection is a total joint replacement infection with a known source. So obviously the group we're interested in is the primary because that's what it would be if it was IV self-infusion. We did a total of 49 joints, 39 knees, 10 hips with a median follow-up of 6 years. The first study that we published had a much higher rate of HIV than the second study, which was about half as much. And that's not surprising because obviously treatment was a lot better. But the CD4 counts were there were actually less patients under 200 with the second group than the first group, and the average was less. And the demographics were essentially the same. Okay. So looking at the two groups, there were no early infections. We had no infections in the first 6 months, which was Dr. Ragney's criteria. We had none in either study. We had 16% incidence of primary infection, blood-borne infection in the first group, 0% in the second group. And that is the group that got education in IV self-infusion. Secondary infection, we had 2 patients in the second group. Those are infections with a known cause. One patient developed an infection in his elbow, and then that spread to his knee. The other was a patient who had multiple surgeries on his knee and fell and opened up the wound, and that got contaminated and that got infected. Those are known sources. So we believe the primary etiology of late infection of total joints in patients with hemophilia is IV self-infusion, that a protocol-driven patient education program can significantly reduce the rate of infection, and that where possible, new therapies not relying on IV self-infusion, like Hemlibra and other things like that, gene therapy, et cetera, should be utilized in patients that have total joints. So let's talk a little about the elbow. The main problem with hemophilic arthropathy of the elbow is the outer part of the elbow. That's the outer half. That's the radial head that is responsible for your forearm rotation. And that gets rough and irregular, and it catches and it pinches the synovium and causes bleeding. And progressive arthropathy, narrowing of the cartilage, and pain. So the treatment of that is actually very simple. Just take out the radial head. You don't need it. This is your hinge part of your elbow over here, the ulnohumeral joint, and it works just fine without the radial head. This is probably the largest radial head we've ever seen. It's huge. It does not allow the patient to rotate their arm, and they're much better off without it. So looking at pain relief for this procedure, you can see our study, Dr. Siller and myself, from 2007, the Mayo Clinic elbow performance scale, 41.2 out of 45 is very good. 45 is the best. The visual analog scale at a large study, the patients improved from 6.5 to 2.2, which is pretty respectable. Now, it's interesting to speculate as to why that is, because all we did was take out the radial head. We didn't do anything very much. We did a little debris mop, but we didn't do much on the other side of the elbow, which also had arthropathy. So here's a possible explanation. When you take out the radial head, like you see here, the axis of the elbow shifts. That opens up the other half of the elbow. That's like a decompression. And we think that may be why these patients did so well. On the right here is a patient that had a radial head excision a long time ago, but that's not what you're really seeing. What you're really seeing is bone loss, bone resorption because of chronic synovitis. Well, it's interesting. This patient has full range of motion, has no pain. Yes, he has a boggy elbow because of the synovitis, but basically he has no pain because the bones aren't rubbing together. So elbow replacement, will look at pain relief and elbow replacement, but keep in mind also durability. So a whole bunch of studies have been done. It's not in as wide use now as it was because of issues we'll discuss. It's reasonably good in terms of pain relief. You can see, Chapman's study, four had no pain, 2 had mild pain, 1 had severe pain and needed further surgery. And elbow performance scores improved into the 40s in many of the patients. This compares the elbow pain to knee replacement, hip replacement. So here is the average elbow pain in Wang's study, looking at his knee replacements, much better, 1.9, 0 being no pain, and total hip replacement, as we mentioned before, even better. So Retchelow's study, visual analog scale went from 8 to 0. The important study here really is this last one, and this is Ernst Brunner, and we'll spend a little more time on this. If you look at his revisions of his cases, 38% of the elbow replacements needed a revision. So totaling this up, there were 6 articles, 46 elbows. There aren't large series of elbow replacements in hemophilia. Follow-up was 8.5 years, which is reasonable. Infection rate was high, 13%. Revision rate was quite high, 22%. And the need to remove the implant completely was moderately high at 6.5%. Not very durable solution. So we'll move on with the ankle. And this is the most commonly involved joint beginning in childhood. It isn't the one that has the most surgery because usually people can get along fairly well. But classical of hemophilia, in addition to wearing down the joint surface, you see these large bone spurs in front? Those shouldn't be there. Those are exostoses, we call them, bone spurs, and they bang into each other and they pinch synovium and they cause bleeding and cause pain. But you can also see there's no cartilage left in this joint. no space, bone on bone. Furthermore, a lot of the patients end up with the ankle down, what we call equinus. That's because of its similarity to a horse ankle, and they can't walk flat-footed with their foot flat on the ground, which is a major problem. Excuse me. Okay, the three different patterns of arthritis of the ankle. One is just the tibio-talar joint. That is the true ankle joint. That's the joint between the leg bone, the tibia, and the talus, the small ankle bone. That's the most commonly involved. Next, you have patients that have that joint involved, plus the joint between the talus and the oscalcis, so-called subtalar joint. Both of those involved. The least common is just the subtalar joint. In our view, the solution to that is fusion, not joint replacement, but we'll talk about that. And that can be relatively easy to accomplish by cleaning out the joint, putting on screws and plates, or just screws, depending on how much is involved. So here's a movie of a patient, hemophilia patient, that had bilateral ankle fusions. Wait, I'll play it again. So I have seen a number of ankle replacements that were referred in. Usually the ones I've seen had pain. That doesn't mean they all have pain. They don't. But obviously, if they're coming to see me, they have some kind of problem. The other point is they're very stiff. It's the arthrofibrosis. It's the tendency of hemophilia joints to get stiff. The ankle with hemophilic arthropathy is a very stiff joint. Oftentimes, they have no motion at all before the surgery. While fusing that joint, they don't lose any motion. All they lose is the pain. So looking at ankle fusion, you can see that in this case, Bluth's article, 75% had no pain, 3 had mild discomfort, and Eichler's study, 87.5% had no pain and 12.5 had moderate. So we look at ankle replacement, and the initial results are pretty good. So American Foot and Ankle Society rating, post-op pain 37.3, 0 to 40, 40 being no pain. These scales are oftentimes reversed. So 40, so that's really quite good. And we look at the visual analog scale, went from 7.1 to 0.8, quite good. Same thing with Ecker's study, with post-op pain of 1.9 is pretty reasonable. That would be in the mild to moderate range. Well, let's look a little bit more closely at that study by Eckers, published in the journal Hemophilia. So 17 ankles, which is a large group for ankles, in 14 patients. Pretty good follow-up, 98 to 2012, 9.6 years median follow-up. Reoperations 5, revisions 2, fusions 1, release of adhesions 2. So quite a bit of reoperation. And look at the Kaplan-Meier survivorship. As time, not surprising for an ankle replacement, as time goes by, the failure rate goes up and the survivorship goes down. But to me, this next item is the key. All of the patients with the ankle replacements, all of the patients showed signs of component loosening. Remember, we were talking about the polyethylene and the loss of bone around the implant, and the implant getting loose, the implant getting painful. That was happening in every single one of these cases. And it happened as early as 3.3 years and as late as 17.8 years. And then they got degeneration of the joint below the ankle, that subtalar joint that we talked about. That's not encouraging for ankle replacement. Now, if there may well be people in the audience that have ankle replacement or maybe considering ankle replacement, and I would say to you, they have gotten better. We don't have good data on the newer ones because they haven't been around long enough. But I think they are getting better. But for my money, you're much better off with a fusion because that's it. Once it's solid, you're not going to have to reoperate on it, at least with maybe very, very rare exception. So in summary, total hip replacement, excellent pain relief, excellent durability, especially with a highly cross-linked polyethylene, the newer material. Knee replacement, excellent pain relief. Post-operative periarticular injection, it's called PAI, periarticular injection, really helpful with post-operative pain. Later on, some kind of mechanism to assist you in getting your range of motion so you can get an accurate measure of your range of motion as you exercise at home. And obviously crucial is prevention of infection. Radial head excision, excellent pain relief, surprisingly good considering we're just doing half of the joint. Elbow replacement, good pain relief, but variable, and durability is still an issue with that procedure. Ankle fusion, excellent pain relief. Concern about are there any other joints involved besides the ankle? If the subtalar joint is involved, it needs to be included. That's important. And obviously, ankle fusion is very durable. Ankle replacement, good pain relief, high pending failure rate at 10 to 15 years. So not as good long term. So pain management is an issue with patients on long-term opiates. So if we see a patient who needs a knee replacement or needs some kind of an orthopedic procedure, and they have been taking large amounts of opiates, really important to get them into good pain management and try and get off of the large amounts of opiates, hopefully off of them altogether. Prior to the surgery, their recovery will be much better. And I think that's everything. I'd be glad to answer questions if there are some.
Thank you so much, Dr. Luck. Yeah, I just wanted to remind everyone, if you have any additional questions, please feel free to put them in the chat. So we'll start with the first question that I have. Let me just grab in front of me. What is about the youngest age that you can be a candidate for a knee replacement? But I guess to add on top of that, the youngest age for any of these procedures, just generally as well.
Yeah, it really varies with the procedure, but in terms of knee replacements, we have gone down into the early 20s, not commonly. It depends on the circumstance. We recently were shown a case of somebody from out of state who has just an absolutely terrible knee, and he's young, he's in his early 20s, and he basically is completely crippled. And what are the options? Well, we could fuse the knee if we didn't want to do a knee replacement, but a fused knee makes the knee replacement in the future more difficult. Furthermore, a fused knee is a very cumbersome gait. And in hemophilia patients, if they have ankle involvement, and most of them do, fused knee's not a good thing. And there's quite a bit of literature to show that you are better off with an amputation than a fused knee. So given that situation, we are willing to go ahead with knee replacement at a relatively early age. If their situation is fairly severe and if it can't be alleviated in other ways. As far as the other procedures go, ankle fusion, even younger, not before they finish growing, preferably. And usually we don't have to. It's usually a later situation. Again, radial head excision, synovectomy, we usually don't need to do that until people are adults, but we're willing to do adults at almost any age if they have the right indications. And then hip replacement, not in hemophilia, I've done hip replacement on a 13-year-old girl. Her situation, she had a very severe juvenile arthritis and her hips were stuck. She couldn't move them at all. She couldn't move her legs hardly at all. She was just basically stuck. Well, the hip replacement gave her motion. She wasn't going to go around and run and jump. If she could just get out of bed, maybe even get in a wheelchair and get around, that was her goal. And so that's a special situation.
Thank you. Our next question we have is, do you do knee replacements on inhibitor patients? And then if so, what is the recovery and success rate for that? Is it different from someone who doesn't have an inhibitor?
Yeah, knee replacement on inhibitor patients until recently had definitely a higher complication rate. Infection being number one, because they bled into their knees after the surgery. The wound would break down, it would get infected, it'd be a mess. Since Hemlibra, it has made a dramatic difference. And we have begun doing knee replacements on Hemlibra. We cover them with 7A or 7-pack in the perioperative period. So for the surgery, for the first couple of weeks, Dr. Kwan supplements it with 7A or 7-pack. And so far, and we're talking small numbers, we're talking, I think, 3-4 patients so far, but they have done fine. They've not had any more problems in the general hemophilia population. And I'm very excited about that.
That's great. I just got another question in here regarding ankle fusion. Is the surgery more difficult if the patient delays the surgery, resulting in more joint damage?
No, it as long as the patient can get around, as long as their quality of life isn't too severely affected, they can wait as long as they want. It's not going to make a difference in the surgery or the outcome.
And then another one, with fused ankles, is there more stress placed on the knee and hip joints?
Not that we can appreciate. Theoretically, yes. Theoretically, not so much the hip, be more the knee. But keep in mind that our patients who have ankle fusions, most of them don't really have any ankle motion anyway. So they've already had that situation, whatever it is. But I think it's fair to say that if you have a diseased ankle or a fused ankle, yes, it could put a little more stress on your knee. And what we strongly recommend to our patients, whether they have a fused ankle or not, but if they have a stiff ankle, is to wear a shoe that's got a cushion heel, that's got relatively good padding, and stride forward on that. And then, it's like that movie I showed you. That is that type of a shoe, and that patient can walk normally because as they put the heel down, the heel compresses and then they stride forward normally.
Thank you. I have another great question here in the chat. What is the determining point to go for surgery? How long can one prolong or manage the pain before deciding I need to get this surgery?
I think that's a very good question. I'm sure it's a question an awful lot of people have. So it becomes a quality of life issue. These surgeries, the ones I mentioned, especially the knee replacement, hip replacement, ankle fusion, radial head excision, highly successful operations that can be, and the infection rate can be reduced way down by good technique with IV cell infusion. So I would not put it off too long. And what I would suggest to the patients is maybe they talk to some other hemophilia patients who've had the procedure and see what they have to say. I know what we've heard a lot of times from people is they wish they hadn't waited as long. Doesn't mean you should do it before you're ready. You should.
I have another ankle fusion question. What is the recovery time?
That's a good question. So the bones have to fuse. They have to unite. It heals like a fracture. So that takes time, right? So you go in a cast for 6 weeks, non-weight bearing. Yes, there's internal fixation, but those screws will not hold if you put too much stress on them too soon. So a cast, non-weight bearing for 6 weeks, then either a walking cast or a boot, but with that you can get around. So what most of the patients do for the first 6 weeks is they use a scooter, one of these kneeling scooters, and get around pretty well.
Another question we have here, post hip or knee replacement, how much can one get back to normal activities like mobility or driving a car or any other normal type activity?
Okay, so hip replacement driving a car, if it is your non-dominant side, so if it's your left side, and your right side's okay, you can operate the accelerator, you can put on the brake, you can drive the car very quickly, a couple of weeks. If it's the other deal, if it's your right hip that's being done, then safety is an issue. And you don't want to drive a car until you really are safe moving your foot from the accelerator to the brake. And so you practice for a period of time, but I recommend 3 weeks or more. That's for hip replacement. Well, keep in mind, hip replacement is a very quick recovery. Knee replacement is slower. And it's really the same issue. Once you've got good range of motion, once your quadriceps muscle is strong, once PT feels that you are safe to drive, then you go and drive in an empty parking lot. You make sure that you have good control of the vehicle, and then you can drive. So it varies from one person to another, but you don't want to take any chances.
What do you think of ankle distraction to treat ankle arthropathy?
Yeah, there have been some interesting articles out of, well, the ones I'm familiar with are out of Holland, but there probably are others. And I offered to a patient one time, she didn't want to do it. It sounded kind of extreme, I think. She was pretty young, and I thought that would be reasonable. So I think it is reasonable in a younger patient. Now, if it's somebody that's a little bit older, there's advanced degenerative changes in the joint, it's not gonna help. If the cartilage is all gone, if the bone is eroded, if there are cysts up into both sides of the joint and all that stuff, the distraction is not gonna help, not for long enough to be worth it.
Our next question is, how successful are knee replacement revisions?
Very successful. And infection is, of course, a spatial issue. So let's say an implant gets infected, not always, but a lot of the times what that means is we have to take the old implant out, cure the infection, put a new one in. We can do that. We have the capacity to revise multiple times if we have to. So if you're talking about a younger patient and something happens, they need a revision in a few years, and then they need another revision a few years later, that we have the technology to do all that. We can replace not just the knee, we can replace part of the distal femur, the thigh bone. For our tumor patients, we can replace the entire femur, including the hip and the knee, all with a metallic implant. So yeah, technically speaking, revision is very feasible.
Question here is, have you found, are these procedures more common in patients with hemophilia A or B? Is there any sort of distinction?
I don't think so. It hinges a lot on onset of bleeding at an early age. That's when most of this gets started, when the patients are children or adolescents. And I'm not aware of any studies that have tended to indicate a predilection one way or the other. Obviously, hemophilia A is a lot more common, so we see a lot more hemophilia A patients. But if you stratify that, I don't think it matters.
Thank you. And now I believe this is our last question, but again, if you have any last minute questions for Dr. Luck, please put that in the chat. But are any of these procedures, knee, ankle, or the hip, are they done or are they needed because of a lack of treatment from the patient?
Yeah, I think that's probably fair. So if a patient doesn't have clotting factor available in their, say it's from another country or whatever, when they're growing up, yes, they're going to have a lot more severe problems, and they're going to be a lot stiffer and have more severe arthrofibrosis and the whole 9 yards. If they have good treatment available, they certainly want to use it, and they may be able to prevent a lot of the need for these surgeries, or at least postpone it a significant period of time.
Thank you. Oh, I did just get another one in here, so I will ask this one too. Are you familiar with any successful ankle distraction procedures?
Yes, like the old one. I have never done one. I considered one once. The patient didn't want to do it. I don't blame her. What I've read is somewhat encouraging. It's temporary. It's not going to fix the diseased ankle. It's going to help for a period of time. The theory is that if you distract it some new cartilage is going to grow in there. Okay. And that's true. But here's the catch. The cartilage that grows in is not normal cartilage. It's fibrocartilage, it's scar tissue, grows onto the joint surface. And as it does that, then that gives you a temporary padding, but it's not strong. It's not going to hold up. And as you walk on it and use it and stuff like that, then you're back where you were before.
Thank you. I was going to finish, but this question just came in. I actually think this is a great question we probably should have started with. What is ankle distraction?
Yeah, a lot of people probably don't know. So basically, you put on an external fixator. So you put pins through the bone above the ankle, pins through the foot below the ankle. Sounds a little bit grotesque, but it isn't. We do it for severe fractures and severe injuries, soft tissue injuries, etc. It's in common use. And then these are attached by bars. So if you can envision, say, 3 pins through above the ankle through the tibia, 3 pins in the foot, connected by bars that you can distract. They have threads on them, and you can open it up, and you can increase the space in the ankle joint. It works very well. But like I said, what's going to grow in is not normal cartilage. It is fibrocartilage.
Well, thank you so much, Dr. Luck. I think that's all of our questions for the evening. I will stop it here, but we appreciate you coming on. I thought this was a great presentation, so informative. I think for everyone else as well, we had so many great questions. So really appreciate you coming on and giving this talk. Absolutely wonderful.
I'm very glad to do it, and I really appreciate your organization. And Casey, if you want to share my email, if people have other questions and things, that's fine.
Okay, absolutely. We can do that. We can share that in the chat or send that out in a follow-up email to everyone. Okay. I'll make sure we get that in the chat for you all tonight. Well, so thank you so much, Dr. Luck. We